Patients who are confused, disoriented, or repeatedly fall, or are trying to remove medical devices such as oxygen or IV lines often require temporary use of restraints to keep them safe. Restraints are not a solution to a patient problem, but rather a temporary means to patient safety. Restraints can be either physical or chemical. Use of physical restraints should be used as only a last resort when a patient's behavior places them or others at risk for injury. Side rails are often a type of restraint that may be hazardous if a patient attempts to clear the rails to exit the bed. Chemical restraints are medications such as anxiolytics, sedatives, and are used to manage a patient's behavior and are not standard treatment for the patient's physical condition. The use of restraints is associated with serious complication resulting from immobilization, such as pressure ulcers, pneumonia, constipation, incontinence, and in some cases death, as a result of restricted breathing and circulation. Before applying restraints, nurse should assess restraint alternatives, including reorienting the patient, explaining all procedures and treatments, offering diversional activities, assigning confused patients rooms near the nurse's station or providing direct supervision or sitters, attending more frequently to their toileting, food, and nutrition needs, camouflaging IV lines with special stockings or clean dressings, evaluating all medications the patient's receiving, and ensuring effective pain management. For legal purposes, nurses must know agency-specific policies and procedures appropriate for the use of monitoring restraints. The use of restraints must be clinically justified and part of the patient's prescribed medical treatment regimen. A physician order is required based on face-to-face assessment of the patient. The order must be current, state the type and location of restraint, and, specifically, the duration and circumstances under which it will be used. These orders need to be reviewed within a specific time frame according to the policy of the agency. Restraints are never ordered on an as-needed basis. Ongoing assessment of patients who are restrained include proper documentation, including behaviors that are necessary for application of restraints, the procedure used in restraining, the condition of the body part restrained, for example, the circulation to the hand, the evaluation of the patient's response to the use of restraints, and the nurse must assess these restraints and remove them periodically to assess the need to continue restraints as necessary. Seizure precautions is another safety risk. When a seizure begins, the nurse should note the time and stay with the patient, and they should call for help. The nurse should track the duration of the seizure and notify the healthcare provider immediately. The nurse should have staff member to bring the emergency cart to the bedside, have suction equipment ready, and be available to maintain the airway and patient's oxygenation status. The nurse should document the episode appropriately and position the client safely. The nurse should not attempt to lift the patient from the floor to the bed while the seizure is in progress. However, the nurse should clear the surrounding area of furniture, and if the patient is in bed, move pillows and raise the sides to promote safety. If possible, turn the patient to one side and the head tilted slightly forward to allow the tongue to fall away from the airway and allow drainage of saliva. If possible, the nurse can also provide privacy and have staff control the flow of visitors in the area. Do not restrain the patient or hold the limbs loosely if they are flailing. Place something soft under their head and loosen the clothing or collar to prevent suffocation or musculoskeletal injury. Once the seizure is over, the patient can be placed in the side-lying recovery position and the bed in the low position with seizure pads on the bed rails for safety.